Okay, so now we have an overview of the most important pediatric neurologic and neuromotor impairments or disorders that you need to be aware of. First up is head trauma. So head trauma causes close to 500,000 ED visits annually in the pediatric population, and that's up through about age 15 is what they're measuring. It is the most common cause of disability and death in children. The most common causes are injury, obviously, falls, motor vehicle accidents, and non-accidental trauma. And what we see in clinical practice is a wide variety of results of those traumas. So skull fractures, and those can be mild, moderate to severe, concussions, and these are definitions here for you. So a concussion is defined as a traumatic injury that alters brain function, and it always includes the loss of awareness or alertness. So the person has blacked out or things have become fuzzy, and that can be briefly, very briefly, or over a longer period of time. A contusion is localized bruising, so right under the site of the trauma, and there can be bleeding and swelling to that area. So not necessarily having blacked out, and not the same as a concussion. A laceration is tearing of the internal cerebral tissue. And then we have various types of intracranial bleeding that can go along with these injuries. So most important when a child presents to your ED or urgent care or wherever you're working with complaints of a head trauma, you want to take a good thorough history and find out the circumstances of the event or accident, how it happened, where it happened, any signs or symptoms like did they black out or were things kind of fuzzy around the event. So a good detailed history. And then a physical assessment. Any events or things leading up to the time of the accident, you want to know that as well. I know with teenagers, we want to know if there were drugs or alcohol involved. That's, of course, not pertinent with our younger kids. And then on your physical exam, you want to assess for loss of consciousness. And then on the next slide, we'll go through minor, moderate, and severe injury. But you would expect to find possibly dizziness, headache, blurred vision, maybe some nausea, vomiting. And then certainly for younger children, we're always going to assess for non-accidental trauma. And that is exactly as it sounds. It's a trauma that was not an accident, so physical abuse that was caused by parents or caregivers. So here is your pediatric Glasgow Coma scale. In Peds, it's shortened down to this brief scale, and then it's got some age-appropriate markers. Obviously, you're not going to elicit the same responses in an infant that you would in an older child, but here you go. You've got eye-opening, response spontaneously or to pain only or no response, going through the motor response, so reflexes, flexion, extension, things like that. And then verbal response, are they oriented? Do they remember things about their day, what they had for lunch, things like that. And we worked through some of these during the the skills lab day, those of you that were there. And then in an infant, it's not present here, but in an infant, we have other scales that we use for a nonverbal infant that includes things like their pupillary reaction and their vital signs. In older kids, you can also assess their motor function, have them stand and balance, see if they can walk in a straight line, if they can hop, things like that. So brain injury, these are the signs and symptoms that you'll find on your assessment. And things can change during the course of your time with the patient. So I actually have an example. Last week, I went on transport to pick up a patient that had suffered head trauma, and the admitting provider had actually noted more of a normal exam, but by the time we arrived and I saw the patient several hours later, I documented signs of a mild brain injury. And so then I took precautions to cool the patient because it was a witnessed, it was actually a witnessed event where they were hypoxic. So, and brought them back to our main hospital. And then the patient quickly deteriorated and moved to more severe, where there was no longer a response, active seizures, apnea, and fixed pupils, bradycardia, so the works in terms of severe as it could get. And that's because if you have active bleeding or you have brain swelling, things can get worse over the course of time. So for mild brain injury, you may or may not have loss of consciousness, confusion, they may have some nausea and or vomiting, pallor, they can be irritable or lethargic, and drowsiness. For moderate brain injury, you would have the symptoms seen under mild, as well as an abnormal vital signs or a sudden change in vital signs, and altered mental status. And you may also have focal deficits. So focal means not global, very one-sided or specific to one area. So you may have slurred speech, you may have loss of vision on one side, or hearing impairment, or a loss of strength or movement of one part of the body. And that tells you that it correlates to damage on one side or the other of the brain. And then you may also see increased agitation. And then signs of severe brain injury, you've got all of the signs and symptoms of increased intracranial pressure. And so nausea, vomiting, blurred vision, confusion, an inability to follow commands. So if you're directing the child to, raise your right hand or do something and they're not understanding you, that's a sign of a more severe brain injury. And then seizures, of course. And late signs then would be kind of a collapse in all systems, altered pupillary response, posturing. And in your book, they describe the two types of dysfunctional posturing. So flexion is severe dysfunction of the cerebral cortex, and that's when the arms, wrists, elbows, fingers, all of your upper body extremities are flexed and bent inward towards the chest and legs. And then your feet are also rotated internally. And that's dysfunction of your cerebral cortex. Severe dysfunction at your midbrain shows backward arching of the legs and arms. So hands not flexed, but hands, twisted, flexed away from your body. Extended neck, clenched jaw, and an arched back. And this is extension posturing. And those are actually important for you guys to know in future life and future exam states. So diagnosis and treatment, what do we do when they come in? We're gonna, backing up, you wanna support your ABCs always, right? So if they are showing moderate to severe signs and symptoms where they're having vital signs changes, you want to support your respiratory and cardiac systems first. So if they're having desaturations or apnea, you're going to want to give some respiratory support. If they're bradycardic, if they're or tachycardic, you're going to want to assess for that and support those things as well. So stabilization first. And then in terms of diagnostics, a blood gas will give you information in terms of whether the damage has been so severe that it's causing metabolic acidosis. And then also if their respiratory system is suppressed so much, you'll have information there. A CBC, I would do not to look for infection, but to look at my hematocrit and my platelet count to see if there, is blood loss in the brain internally. You might have a hematocrit drop, although you don't have baseline labs on this particular patient, so you're looking for some severe or moderate anemia. And then it's always good to make sure that your platelet count is okay, so you're assessing for the ability to clot. And electrolyte abnormalities I would not expect before the trauma, but certainly after the trauma to the brain, you can have some electrolyte disturbances. So if you have a patient who is either actively seizing or needs urgent emergent cardiorespiratory support, it's not really ideal to go run for a stat MRI. In fact, there is no such thing as a stat MRI, and the MRI techs will tell you that if you try to order one. So certainly you can get portable x-rays just about anywhere in the hospital. So that could be a first line in the ED, and it won't show you necessarily where there is damage or bleeding in the brain, but it could show you skull fractures, and also if you have maybe some blood external to the skull, so maybe you have a hematoma outside the skull, that would show up there. A cranial ultrasound is not really a gold standard for looking at these kinds of things. But certainly if you can't get your patient to CT or MRI, you could do a quick cranial ultrasound. They can come up stat, and that'll just give you some rapid information as to whether there's internal hemorrhaging or not. So really, if you need a stat study and you're worried about head trauma with bleeding, you would want to try to get a CT if you can get one emergently. And that'll show you whether there is some internal bleeding. And we worry, you can bleed anywhere in the brain, but we worry about those areas where it can cause brainstem compression. And so those kind of things can be treated surgically, emergently as needed. If the patient is fairly stable and you're going to admit them to be observed overnight, then you could arrange for an MRI the next day that will give you more information. And then, of course, treatment, depending on where the injury is, that's going to guide what kind of treatment is available. So most of the time, it's just supportive care while they're getting over the injury. And if there is bleeding, only if there's pressure in some of the more critical areas would neurosurgery do something, but most often it's just we wait and watch and see how things evolve. So here's a picture of, these are image slices of a brain in MRI. And so on the first picture A, that's at the very top of your head, so you're looking down onto the brain, and you can see where the arrow points. There's just some blood and fluid there on the right side of the brain. In picture B, you can see that blood collection shows up black and it's causing compression on the brain. And then in slice C, where the arrow is pointing, there's a little white mark, and that's area of the brain that's been damaged or affected by that trauma. Okay, so your nursing priorities. First up is going to be stabilizing the patient. And once you do that, you want to monitor for increased intracranial pressure, and you want to initiate precautions that will minimize or decrease further trauma. So monitoring vital signs, monitoring level of consciousness, doing your frequent neuro checks that include checking pupils, motor activity, sensory perception, etc. And we use the Glasgow Coma scale. We keep it at the bedside so nurses have access to it. Let's see, it may be indicated to use padded restraints if the patient is overly agitated. And again, this is not their normal personality. They may or may not have control over such agitation. It's caused by the trauma to that area of the brain. You want to keep the head midline with the head of the bed elevated to at least 30 degrees, and that's going to promote venous drainage of the sinuses. Avoid any extreme positioning, either flexion or extension. And then try not to do anything traumatic to the patient that will increase ICP, like aggressive suctioning. And of course, you also don't want them to be coughing or blowing their nose, because that can increase intracranial pressure. Let's see, you also want to promote tissue perfusion. You want to manage disturbed sensory perception and try to minimize things, provide a calm, restful environment, have them conserve energy, and minimize visiting. You just want to keep things calm and quiet, and hopefully they're in a patient room where they don't have a crying baby next door. Of course, in Peds, we mix all age groups, so you never know who your roommate is going to be. And then IV fluids, monitoring intake, output. Sometimes if you've had a bad brain injury, you also suffer, the brain controls electrolyte balance and renal hormones, so you want to watch your intake and output as well. And then any complication, or anytime you have trauma, that you can have complications such as bleeding, cerebral edema, and seizures. So you're monitoring for those things the entire time the patient is under your care. So some considerations that are specific to children, primarily that the brain is still growing and developing. Kids are constantly, their neurons are growing, they're building new synapses, they're shaving off old connections that they're not using. And so if they suffer a severe or a moderate to severe brain injury during the time of development, that can cause developmental delay and can set them back. And also they can, it can change how they think, and it can affect areas that are responsible for developing appropriate behavior. So unfortunately, in kids, because they're not fully developed and fully fledged yet, it's hard to really assess for those kinds of changes until they reach that stage of development that that stage that they're supposed to be at 5 years from now. So you may not notice that they're having deficits for some time, and that can be kind of difficult. So, they can feel the effects of an injury they had years ago, and it maybe wasn't recognized. Returning to school can be very difficult, especially with, I think there's been a lot of press more recently with head injury, concussion from sports. And so I'm glad there's more of a focus on that, at least in the sports world. But these kids can, recover and get back to class, and the teachers and their parents don't necessarily change expectations of them, but they can really struggle and continue to have trouble with memory and comprehension, lack of energy and difficulty concentrating or focusing, and having headaches. And really they can have lasting effects for 6 months to a year, sometimes longer, and where their brain is just still recovering from illness. And so we need to, teach parents to continue to look for signs. They should definitely go to follow up. If it's available in their city, we have certain pediatric specialists that work with brain trauma and concussions, and they have great assessment tests where they can track your progress in recovery. But just reminding parents that they're not going to be feeling quite up to their best for some time, and to give them a break, and ask the teachers to give them frequent breaks as well. Also in developing, especially teens, They'll go through some social and emotional problems related to their brain injury. Just everything else that we've talked about in the teen world in terms of anxiety and depression. And then if you layer something like this on top of everything else that they're trying to fit in and be popular and all of that stuff, and then you put a brain injury on top of that, they can really go through some emotional problems. So these are just some that I've pulled from the book. Denial that the injury will have a long-term impact. I mean, they need to really slow down and prepare themselves that it's okay to take it easy and not to have high expectations if they're not functioning at their best. They can have grief over loss of function, and that will change how they relate to others. Frustration with the recovery process, obviously, and self-esteem issues can go hand in hand with some of these things. Okay, on to seizures. So what is a seizure? A seizure is a symptom of a disease process or something going on with the brain. A seizure is not a disorder in and of itself. And seizures happen when there are electrical discharges of the neurons that are just firing out of control within the brain. And it's abnormal, and then it causes these physical discharges within the body. And that's different from epilepsy. So estimated 4 up to 10% of all children have had a seizure of some sort, and there are multiple causes. So fevers or infections, it can be caused from head trauma, hypoxia, so any situation where there's a lack of oxygen to the brain. It can be caused by toxins or drug overdoses, and heart arrhythmias, which could throw blood clots or, again, a disturbance in blood flow to the brain. And then epilepsy only occurs in up to 3% of all children, and that's a disorder. So that's a chronic recurring disorder where the patient or child is having unprovoked seizures. So we don't diagnose anyone with having epilepsy until we've ruled out all the other possible causes, and they have to have 2 or more unprovoked seizures to be called epilepsy. So here's the definition then. 2 or more seizures unprovoked within a 24-hour period, or 1 unprovoked seizure and a chance or risk of more. So chance or risk categories would be based on either some trauma to a certain area of the brain where we think there's a high suspicion of seizure disorder, or genetic condition that puts them at higher risk for having a seizure disorder. So if you have that risk category, plus you've had a witnessed unprovoked seizure, then we will call it epilepsy. And there are a couple of, in addition, some syndromes, specifically epileptic syndromes, that also fall into this category. So the pathophysiology, just like the definition, there's a disruption of electrical communication among the neurons in the brain. So they either fire when they're not supposed to, or they're not firing when they should. So they're firing at off times when they're not supposed to be firing. So there are a bunch of classifications of the different types of seizures. And it's, as a nurse, it's a little overwhelming to get all of these down. I think the most important thing is that you recognize as a bedside nurse some abnormality in your neurologic exam, plus some abnormal movements, and then get a provider or your charge nurse or one of the experts to come help you assess what's going on. We certainly get called all the time for what is thought of as abnormal movements in kids, and so always better to be safe rather than sorry and alert the providers if you see something abnormal. So what I've put together are a bunch of YouTube videos, and I understand it's time consuming, but I think it's really worth it for you to watch, go through all of the videos so you can witness the differences in the types of seizures. So first up is focal partial. So focal meaning to one area, and there are simple partial and complex. And these types of seizures we often see when one hemisphere of the brain is affected. Usually things like a stroke, which is one-sided, will cause seizure or abnormal movements in the opposite side of the body. So if there's a stroke on the left side of the brain, you'll have seizure or abnormal movements on the right side. So you can watch that there. And then for generalized seizures, these are things usually caused by trauma or injuries that have affected the entire brain, whether that's encephalitis from an infection or hypoxic ischemic injury that affected the entire brain, and or other seizure disorders or electrolyte disturbances, lots of things that can cause them, but this is something that would affect the entire brain. So the first is a video of absence seizures, where I believe this was a young woman, and so they are talking and then all of a sudden just check out or blank out, and they come back in, they're conscious the whole time, and they have memory of what they were saying, but they just kind of check out for a moment. And then you have tonic, clonic, and tonic-clonic. So tonic seizures are muscle stiffening. Clonic is jerking. And then if you have tonic-clonic, you have a pattern of stiffening and jerking, which alternates. And some of these kids go through different, they start with tonic and then they move into tonic-clonic, and that's fairly typical. And then myoclonic seizures, you have just jerks, like full body jerks. And atonic, atony, or loss of tone, is a complete loss of all muscle tone and control, and those patients fall to the floor. So these are very difficult to watch, some of them, and you'll notice in the videos that some of the parents don't seem very excited because they're accustomed to it. Their child has a seizure disorder, they live with it. But while you're watching the video, think of what your nursing precautions would be, because the mom in one of the videos is not doing it. But you want to, protect their airway. You want to guide them to the floor. You want to remove things that could hurt them, roll them to their side, and we'll go through that on the next slide. So please watch through the videos, and let's forward on. So diagnostic workup for someone who's coming in having seizures. I mean, often they come in and they're a new patient and these are new seizures, and so you're going to do a full workup, including all of the labs, and you also want to rule out infection. So I didn't put it on there, but you're going to do a blood culture and a CBC. If you're concerned for infection or meningitis, you'll also do a spinal culture, so CSF. And then escalating the care, an X-ray, a CT, an MRI, all of those pictures of the brain that you're able to get. And then for seizures, an EEG, and we have kind of cheap bedside EEGs that we can put a patient on urgently. And then you would want to get a neurology consult and have the patient on video EEG. And we usually do that for 24 to 48 hours. And then you can correlate what you see electrographically on the EEG with the outward signs, so the physical signs on the video. And then while they're on video EEG, we will then give medications to stop the seizures. So we know that allowing the seizures to continue can cause more brain damage. So we try to treat and suppress things as much as we can to get the seizures to slow down. for some of the kids in those videos who have seizure disorders, if they're having a lot of breakthrough seizures, they're not on optimal treatment, and their quality of life will suffer. And so kids, because they're changing and growing and putting on weight, they need their doses optimized. They need levels of their phenobarb or Keppra or whatever they're on. They need blood levels followed so that we can optimize the dosing. And if their medication is not working, then we may need to change to something else as well. So nursing priority considerations. Safety is obviously number one. Maintaining airway patency. If you're in the hospital setting, you want to have suction and oxygen available. You want to monitor their airway and breathing and supply whatever they need. You want to then ease the child to a safe location, so sliding them out of their chair onto the floor and staying with them, removing any other hazards. You want to make sure they're not hitting their head on something hard, and so if you can supply something soft under their head, that helps. For conscious seizures, you'll see in the video, some of the moms are just using soothing talk, and it's okay, I'm with you, I'm going to stay with you. So anything you can do to reassure them and reduce their anxiety. Don't restrain the seizure, just let it play out, let it run its course. And if you're witnessing it, if you have extra people, you want to look at your watch and document the timing. And you always want to describe it. So providers, we want to know, which side of the body. Is it one side only? Is it total body? Is it upper extremities or lower or both? So describe the seizure as much as you can. And then you may be preparing to administer medications to get the seizures to stop. And depending on the severity of the events and the situation, you may be, giving maintenance medications orally once the seizure stops, or if it's a new workup, you would be placing an IV and giving IV meds to get things to settle down during, while you're getting all of your other diagnostic information. And then post-seizure, which I didn't include on the slide, but you want to continue to keep them in a sideline position until you make sure that their airway is clear. They may throw up or spit up. They may lose control of their bladder, things like that. So make sure their airway is clear and patent, assess breathing, check for injuries to the tongue, cheek, things like that. Do a neuro check. Assess whether they're oriented, back to their prior state, and then get them into their bed and continue to maintain seizure precautions. So padded side rails to prevent other injuries and make sure the bed's down to the lowest position. It's hard with younger children. Toddlers should be in a crib with rails all the way up so that they can't fall out of bed. But hard to keep kids in bed. They don't understand seizure precautions. Like, it's harder than with a teenager or an adult. So stay with the patient. Don't offer food or fluids right away until they're fully conscious and back to normal activity. And then assess for aura. So sometimes they can have aura-like symptoms after, and certainly they can have pretty extreme fatigue afterwards. So you want to document all of those things. Oh, and on to the next. So neural tube defects are not in your chapter for neurologic and neuromotor disorders, but this is in your, in the section on OB, neonatal disorders. And so Anita's asked me to cover that here. And then when you're doing your ATI, there is a section on neural tube defects. And also when you're studying for your NCLEX later on, it does fall under this chapter. So I think it is appropriate here. Formerly called neural tube defects or spina bifida we now call it, there were 3 degrees of severity. Spina bifida occulta is the most minor, meningocele is a moderate defect, and then myelomeningocele is the most severe. So what's happening is during development in the womb, the neural tube fails to close completely, and you can have an outpouching of either just the spinal nerves, and that would be in spina bifida occulta, where the nerves are out into the spinal surface, and the skin is usually intact, but you may have like a dimpling or a little tuft of hair there. So we always examine babies after they're born and make sure that their the skin is intact. Meningocele, there's a protrusion of a sac, and it looks like a cyst that can have meninges and spinal fluid. And then with myelomeningocele, the most severe form, you have a sac with meninges, spinal fluid, and a portion of the spinal cord and the nerves. And that sac can rupture, and you can see in this picture here that there's leaking of cerebrospinal fluid. So often this is diagnosed prenatally, and so we are aware of when that's coming into the hospital so that we can get ready and be prepared to handle something like this. But just looking at the picture, what would some of your most immediate nursing considerations be, and what are you going to be worried about, and what is this patient at risk for, just looking at that open sac with spinal fluid? I'll give you a second. So I'm most worried about infection. So you have a direct route of any of the skin bugs or any of the bugs that we've touched on our hands to directly enter into the spinal fluid and into the brain. So they're high risk for infection and meningitis. So when we're ready to get a baby like this, we have all sterile gear on in the delivery room, and we have sterile dressings, and we actually place the patient in a sterile bag until we can get them to surgery. So the goal is to have the patient born near a pediatric surgical center. And so that means that patients coming from far away, like Alaska or Idaho, Montana, they need to plan to deliver in a big city somewhere where surgeons are prepared to handle this. As the patient is born, we want to check reflexes and spontaneous movement. Because you've got the spinal tract out and open, you can have decreased neuronal control of everything below that. So we're talking about bladder and bowel function. They can be incontinent, and they can have decreased movement of their lower extremities as well. So these patients go immediately off to surgery. And a couple of the other little caveats are that these patients, for some reason, always have a latex sensitivity or latex allergy. And we're not sure why that is. It hasn't been widely studied, but we always use non-latex equipment. And the allergy response can range widely from hive-like rashes to wheezing, which can progress to anaphylaxis. So we're really careful about exposure, and that's a lifelong allergy or sensitivity. So that's one of the nursing considerations. And then post-op, there's a whole lot of things. So once they close up, and they tuck in whatever was exposed, whether that's meninges, spinal cord, nerves, etc., and they close it up. But as they do that, that can often tug on the lower part of the spinal cord and where the fourth ventricle is, if you can see on this picture of the brain. And that can cause obstruction of the flow of the spinal fluid. And so these kids often end up with subsequent hydrocephalus. It goes along with the spina bifida or myelomeningocele. So they're they're high risk for hydrocephalus. And so hydrocephalus means fluid on the brain. That's the literal translation of the Latin. And so because the spinal fluid accumulates and it can't exit down the spinal tract, you get swelling on the brain, and that fluid can get so accumulate so much that it then causes pressure on the brain and the structures. And so that can cause long-term developmental problems. These kids often then end up with a shunt placed to relieve the pressure in the brain. So, you know, once the defect is sutured up and healed up, that doesn't mean that the problems go away or that they don't then have lifelong problems. So I don't need you to study too much about the long-term hydrocephalus or Chiari malformation. Just know that that is a possibility. You don't have to watch the video here, but what I want you to do is either in your textbook or in your ATI book, look at the complications associated with this defect and the nursing considerations. So skin integrity, latex allergy, and then you're going to monitor for signs of increased intracranial pressure. And then these kids also have, like I said earlier, bladder issues, sometimes bowel issues, and so they need to be on a bowel regimen, and they need to be monitored for bladder dysfunction, and they can get UTIs if they're holding on to urine and not able to void. We often end up teaching these parents how to straight cath their children, and that may be something that they need to do forever during the course of this child's life. And then if they have scoliosis or club feet or lack of nerve control for their lower extremities, then they'll also have orthopedic issues. So those are all your nursing considerations. Okay, on to our last disorder of the day. I'm going to talk about cerebral palsy. So cerebral palsy defined is the most common movement and motor disability. It can affect up to 4 per 1,000 births. There are multiple causes. It can cause abnormal perception and sensation, so it can affect visual, hearing, speech, and cognitive delay, and it also affects the motor function. So these kids have loss of motor control, coordination, and difficulty with posture. Cerebral palsy is a constellation or caused by multiple different causes, but it's a constellation of findings. So it's kind of like a blanket definition or blanket diagnosis. It's caused by brain injury, most often to motor areas, but it can affect other areas of the brain. And so that can happen during a perinatal event. So either a difficult extraction, say a baby gets stuck and has a loss of oxygenation to their brain, it can be caused from that. Or it can be caused from an embolism that's thrown off the placenta, so a blood clot or a fatty deposit that blocks blood flow to the baby, and then the baby doesn't get oxygen to the brain. Shoulder dystocia, I don't know if you guys have learned about that, but that's another event where the baby gets stuck and blood flow is compromised to the baby. Premature babies are at higher risk because they often have or they're at higher risk for bleeding internally in the brain, specifically to the intraventricular area. And that's because they are so small and fragile, and they often have electrolyte disturbances, blood sugar disturbances, and then cardiorespiratory problems. So those things all affect blood flow in the brain. And then the most fragile vessels in the brain bleed and cause damage and swelling in areas in the brain. And then those kids are at high risk for cerebral palsy. This can also happen in older kids from a head trauma, and that can be head trauma like we described with sports injuries or things like that, car accidents, etc. Or it can also happen after the result of non-accidental trauma, so like shaken baby syndrome, and there can be damage to the areas that then later result in cerebral palsy. This can happen from a stroke, and you think of strokes only in older people, but there are certainly events in utero that can cause a stroke. And then we also learned when we were talking about sickle cell anemia that those kids can also have strokes. And so that can damage areas of the brain that control motor and movement. And then HIE, hypoxic ischemic encephalopathy, that's kind of a blanket term, which is also a perinatal event where the baby doesn't get oxygen to their brain for various reasons. So how is this diagnosed? Well, unfortunately, most of these things happen in the newborn period, where there is damage to the brain and then recovery of the brain post the event. But we can't ever tell a family that their child will certainly have or not have cerebral palsy. You're waiting years for the child to develop and develop signs of delay. And so when we're discharging a patient after they've had a moderate to severe incident that affected the brain, I can only give them risk categories. This increases your child's risk 5% or 10% of having cerebral palsy. So it's not until they start to miss their developmental milestones where we might do some extra developmental testing. So some of those things like poor head control, poor posture or rigid posturing, just difficulty pulling up or sitting up or things like that you would expect the baby to develop on a certain timeline. So pediatricians are expertly trained to kind of assess for those milestones. And of course, every child develops a little differently anyway. So even a normal child, they're all going to start babbling at different ages and stages. They're going to start sitting at different ages. So there's a window where we allow a discrepancy, but then at some point there's, you reach an age where not meeting those milestones is then a concern. So the pediatrician is the expert in recognizing those things. And then we're also looking for asymmetry in any of the movements in these kids, and then difficulty with feeding, gagging, choking that would tell you that they're having difficult muscle control in the back of their airway. And any vision, speech, or hearing impairments is going to give you more information about whether there's some delay there. There are a bunch of different ways to define the categories of cerebral palsy, and even the experts have not made a smooth transition into how to categorize these things. There's mild, moderate, and severe cerebral palsy. And then that's further categorized into spastic or non-spastic. And then with non-spastic, you have dyskinetic and ataxic. So I wouldn't hold you tightly to all of those definitions or how to categorize it, but just know that spastic cerebral palsy means tightness in all of the muscles. And that can impair both fine and gross motor movements. So they have a very difficult time in, things that we would normally do or take for granted, like picking up a spoon or a pencil. Those are your fine motor things. And then gross motor movements like walking or sitting or standing. And then non-spastic, what's notable about non-spastic cerebral palsy is that they have these involuntary jerking movements that they can't control. And that can be also difficult to manage. Diagnostic testing for cerebral palsy depends on a bunch of things. So if you were at risk based on having a pre-existing event so that we knew about, maybe we knew you were premature with brain bleeds, we would enroll you in very close follow-up. So your providers would actually be watching for signs of cerebral palsy. or if there had been a head trauma or something like that, we would enroll you in developmental follow-up where we're watching for delays, because the earlier you can get into physical therapy, occupational therapy, you can help with some of the things like spasticity. If you didn't have a history of one of those things that puts you at risk for cerebral palsy, then we certainly would do more complete neurologic testing, and then a bunch of metabolic and genetic lab testing to see if there's something there that would put you at risk for it. And then certainly they may want to do an MRI looking for changes in the brain after something like a head trauma. So nursing considerations, it's highly individualized. These patients, depending on the severity of their illness, mild illness, they may just need assistance with speech therapy or something like that. Maybe it's not that noticeable. They may need a cane or extra support for walking. Moderate illness, they may need additional assistance with walking. I'm blanking. And then more severe, you would expect wheelchair assistance, assistance with feeding, and et cetera. So these patients get communication and speech therapy, they get physical therapy, assistance with feeding tubes, feedings, et cetera. And also think about, for this as well, bowel and bladder control. They may need to be cathed. They may need stool softeners or be on a bowel regimen. They'll need help with toileting and long-term, lifelong help. Kids may need special education, and it's not that they're not cognitively intelligent, but they have delays with understanding and communicating. And then also think about the school-age child, abuse and bullying. They're high risk for that. And then all of these considerations as we transition away from all of the pediatric support and the support of your parents and your medical home as they transition into adulthood, and they are deemed independent, but yet they still need a whole lot of nursing care. So this is a YouTube video, and this is the last of the videos and the last of the lecture, but I think it's really important for you to watch this. It's kind of a, it's a little bit sad, but it's also a little bit sweet. Just seeing there are 3 patients or people with cerebral palsy, and you can see the range of their abilities, and their story is really great. And so I think that'll give you visually what to expect with a child with cerebral palsy. So that is it for this long and detailed lecture on neuro. There's a lot of information here, so I hope that you took good notes, and please let me know if you have any questions. Thank you.